There we go.
Experiencing technical difficulties. Please stand by. And Rob and Karen, it may not be fair, but we're not allowed to vote as the hosts.
Okay. Keep my hand.
How familiar are you?
That's right. With the team, is it something that you are already engaged in? You're just thinking about it, but you're familiar with it. Need more specifics, but unfamiliar, but interested. It's a little bit of a trick question on the last part, because if you weren't interested in the team model, you probably wouldn't be here. All right, just a couple more seconds. All right. Let's see if we can pull the results. There we go. So it's pretty fair, pretty good balance, right? So it seems to be balanced at either end of the bell curve where people are working on it, but familiarity. So this is great. This is going to be our education programming for the day. I'm sorry that we couldn't offer continuing education credits for it, but thank you very much for participating. All right. Rob, over to you, sir.
All right, great. If we could pull up the first slide. And you're on mute, Will.
I am sorry about that. I should go into the mute penalty box. I'm sharing the slide that says team model key features. Can you see that, Rob?
I cannot now.
Well, let me try to reshare.
There we go.
All right.
All right, great. Well, let me get started. So we'll start with a very high level overview of the team model. Team is a real differentiation from what CMS has done previously. It is CMS's second mandatory episode-based payment model. The first one was CJR, which some of you may be familiar with, the Comprehensive Care for Joint Replacement. But the team model is broader. It includes a wider geography. It includes more hospitals. And it also includes roughly 4 times as much total revenue. So team overall is about a $6 billion program. It's a 5-year model that begins. We've got a little bit of time before it begins. It begins on January 1st, 2026, and it'll run for 5 years. The first year of the model is no risk to help people kind of get set up and begin to move. But then in 2027, it will move to a 2-sided risk model. CMS has picked a number of geographies, what they call core-based statistical areas, which are cities essentially, and some rural areas that reside within core-based statistical areas. And within those, CMS has identified about 741 hospitals. Now, prior bundle payment models have been 90-day episodes through bundle payment for care improvement. But because CMS wanted to reduce the variation, they've reduced the post-acute period to 30 days. You can see on the right-hand side the 5 episodes that have been selected for this model. Now, across these 5 episodes, they represent 29 diagnostic-related groups and 8 outpatient surgeries. And we can talk in a little bit about how those are bundled together into the episodes. And then finally, the thing that's really different about this model is the pricing model, because each hospital's target price is based primarily on a regional average in their census division. Now, these are big areas. So I'm in Boston. Boston hospitals are subject to the New England census region, which is about 7 states. If you're in Pennsylvania, you've got Pennsylvania, New York, and New Jersey. So these are large geographic areas where there's a lot of variation. So the prices are standardized. All of the things that CMS does to adjust the prices for wages, for indirect medical education, for dish payments, those are all pulled out. The model does a case mix adjustment in that it calculates the price for each DRG within the bundle separately so that your target price will reflect the services that you actually provide. And then they have a risk adjustment model, which adjusts for a big range of things. And I'll talk about how that works in the next slide. So if we think about the pricing model, the first piece really is calculating the regional prices. So there are 9 sets of regional prices, one for each census division. And the first thing that's done is the standardization, and CMS does this for a number of other programs, standardize the prices, and then within each region, they calculate the episode cost average by DRG across the 29 DRGs that make up the 5 episodes. They use 3 years of historical data. They roll that forward with a 1-year gap by a prospective trend, and those are the regional prices. The next thing they do is take the regional price, and then for each hospital, they adjust the regional price to reflect the mix of patients at your hospital. And so I've listed a set of things that they control for. I will say this model is not very predictive, but it has some predictiveness. The difference between this and BPCI is BPCI puts this DRG factor into their risk model. Here they do it directly, and so most of the power of the BPCI risk model is driven by the DRGs. Here the DRGs are done independently. It's not in the model, so these are really patient factors. So once the regional prices are adjusted for your patient characteristics, then CMS applies a discount, and that becomes your preliminary target price. So I'm going to give just another illustration of how the target price gets built up with a sample hospital. If you could go to the next slide, please. So here I'm using the example of lower extremity joint replacement. There are 4 DRGs in this bundle. There are also 2 outpatient procedures. Now, what CMS has done is they bundle the outpatient procedures into the lowest acuity DRG. So if you look at DRG 470, the 503 cases are a mix of inpatient and outpatient procedures. All the other cases are inpatient. So you can see on the next column, this is the regional base price for this hospital, the risk score based on the model. And so they take the regional base price, they multiply by the risk score, they apply the discount factor, and that becomes the target price. And then what they will do is compare it against your actual spending, and you get the gain or loss per episode, and then that's multiplied by the number of episodes. So you can see here that this particular hospital would lose about $1,500 an episode, mostly concentrated in the hip replacement with hip fracture episodes. But I will point out that if you look at the census region, there are as many hospitals that, not as many, but roughly a third of hospitals make money on hip fractures and 2/3 lose money. So that's sort of the gestalt of the model. So if you go to the next slide, please. All right, so one of the things, because there is a lot of risk, and it's particularly driven by this regional pricing model, is there are risk tracks in the model to provide some protection. So track 1 has no downside and 10% upside for the bundle. So that's obviously the most favorable track. Everybody can be in track 1 in year 1. And if you were designated as a safety net hospital, you can be in that track for 3 years before you go into the next track. Track 2, upside and downside is limited to 5%. So rural hospitals opt into track 2, and safety net hospitals, once they're 3 years in track 1, actually they can opt in earlier, but they're forced to go into track 2 after the first 3 years. If you are an urban non-safety net hospital, after the first year, you are put into track 1. And so now your stop loss and stop gain is 20% per episode. So that's really a much higher level of risk. The way this works, if you haven't been in a bundle program, is that you continue to bill, and all the people who serve the patient bill Medicare fee-for-service. You have this target price. They look at your actual spending every 6 months, and they calculate whether you get a bonus payment or you have to make a repayment to CMS based on your cost relative to the target price. And then there are a series of quality performance adjustments, although they are not very big. So most hospitals, unless you're safety net, are in full risk for some gains and losses starting in 2027. Go to the next slide, please. All right, just to give you, again, a sense of the gestalt across the hospitals, This is hospitals with 200 or more cases. Now, we said there were 741 hospitals in the model. Many of those hospitals are really quite small. Half of the hospitals have fewer than 200 cases. And the hospitals with fewer than 200 cases represent roughly 20% of the total dollars. So really, it's the hospitals with more than 200 cases that represent the lion's share of the dollars in this model. And so looking at this chart, this is everybody who's had more than 200 cases in a year, looking at their gain or loss per episode. This is where they're starting before there's been any activity to redefine care or to improve care. And so you see about a third, a little more than a third, are in the positive. So they're starting this model with a tailwind. And about 2/3 are starting the model with a headwind. And so this is why this model has been somewhat controversial. Go to the next slide. I think there are two things. Because the team model is 30-day post-discharge, in the past, in bundle programs, hospitals have really focused very hard on post-acute care because there is a 90-day post-acute window. And for non-surgical cases, for chronic condition or medical admissions, a lot of times 2/3 of the cost of the episode is in the post-discharge window. For surgeries, a much smaller portion is in the post-discharge window. And so what I advise people to do is you want to look for savings both on the inpatient side through re-engineering and working with your surgeons, but also on the post-acute side. And so when we do an opportunity analysis, of course, the post-acute is a big area for this. And what this is showing for our sample hospital is we're comparing the hospital to its local market and to the census division. And we should have some red circles in there. They're not in there, but I'll just direct your attention to the SNF, the skilled nursing facility, and the IRF, the inpatient rehab facility spending. And when you look at the difference between the hospital and its market, this hospital spends more, they use more post-acute care, and they use more expensive facilities. You compare them with the census division, they're $1,000 higher than their census division average, and they're about more than 1,000, 1.1, 1.2 higher than their cost per case. So they're sending more people, this hospital is sending more people to those services than their local hospitals or their census division hospitals. So we would run this type of a benchmarking exercise across all of the services the hospital is providing. We look at inpatient versus outpatient. We look at those guys separately. And so this is sort of a first start on diagnosing where you have to focus to try and bring some savings in and succeed in this model. So I'm going to pause here and hand it back to Will.
We got some questions.
Okay, awesome.
Are you ready?
Yes, sir.
All right. So Chris asks, for patient factors like HCC, what year will they look at? I think where's the baseline?
Yeah, so the HCCs, they look at the HCCs for the full 3-year baseline period. And so, right, there's a gap between the baseline period and the performance year. So they'll look at the HCCs in that baseline period. So they sort of simulate what your bundles would have looked like back then, and then they look at no, I'm sorry, I'm misrepresenting it. They'll use the patient HCCs from the prior year. That's actually where the HCCs come in.
So let me just actually to clarify that, Rob, to help me understand, is that the baseline year is going to be 2025, or is it is it the 3-year average from 22 to 25?
So in 2026, they'll use the 3-year average from 2022 to 2024. And that's what will be used to calculate the regional average. The regional average is then trended forward to the performance year. So it's basically trended, up to the 2024 and then trended forward by 2 years. And then you're in the performance year. And I'm pretty sure, although I will have to get back to you on that the HCCs actually will be for the current year, but it's possible for the preliminary target prices before they have those, I believe they'll use the prior year HCCs.
That's my understanding. Well, Rob.
Yeah. Okay. Sorry to be confused on that. The second question I see here, will the target price for each DRG be recalculated each year, 26, 27, 28? Yes. The answer is yes. Couple of things. First, they update the data each year. So in 2027, the base period will be 2023 to 2025. So they're using more up-to-date data, and your HCCs for the risk adjustment will be used for 2027. Now, there's something important here because in prior bundle payment models, you were competing against yourself, and the model is rebased every year. And so you saved money and then your price went down. Here, it's the regional price, and maybe 15 or 20% of the hospitals in the region are participating in the model. So you can actually save every year because the region price is not going to change nearly as fast as what a hospital who is working on improving the performance in these episodes. But yes, it is recalculated every year. Let's see, are the figures on my slide number 10 case mix adjusted? If not, isn't there potential higher? Yes. So the answer to that is yes. And the way to adjust for that is basically you divide, and it's pretty simple. We would take the DRG index for these three, for the hospital, the market, and the census division, and we would divide. I've actually done this for this example. It brings the differences down by a couple $100, but not completely. So the question is really a great one, and it's a really important question to ask. And then the next question, assuming that V28 will not impact baseline. So that's true because the risk model doesn't use the HCC score. The risk model uses individual HCCs. So they do basically, just to do a quick rundown, they use patient age category. They use the number of HCCs in the prior 6 months. They group hospitals into 4 size categories. And then they have 25 specific HCCs that they use either in some or all of the episodes, or I'm sorry, some or all of the risk model, because every episode has a different risk model. And so V28 is not really relevant to this.
Hey, Rob, let me just poke my nose in here. V28, for those of the uninitiated, is the new model for risk adjustment coding. So they transitioned for a couple of years. They had V24 and then they moved over to V28, and some specialties like nephrology had a hybrid mixture between V24 and V28 models for HCC, hierarchical condition category risk adjustment factors. We missed one. You skipped right over define gestalt, man. I got to call you on that.
Define gestalt?
Yes.
It's the general feeling or the philosophy and how the model works, I guess, is how I use gestalt. It's sort of the overall, it's the overall philosophy and dynamics. So we have another question here from Joshua Greenberg, the overall goal for this program. So there's several goals, I think, and I'm now not speaking, CMS has written its goals. I'll just tell you what I think the goals are. One is, they're very interested in this idea of a mandatory model, and MedPAC has proposed mandatory models. This information is out. One of the problems is in the voluntary models, there's selective participation. And so it looks like the hospitals are doing much better, but remember, in the voluntary models, generally CMS has lost money, not made money, yet the hospitals have made money because it's selective. So they believe the better way to go is a mandatory model. By mandating it in some areas, but not others, they want to do a rigorous evaluation to say, did we really save money with this model or not? I think the other thing is they're very concerned about surgical quality, and quality and cost really go hand in hand. I will say that, technically, surgeon quality in this country is quite good, but there is variation in the practices inside hospitals and how well they, manage the cases, that they do things like control infection. So it's the internal process. And then there's also the follow-up with the patient after they leave the hospital, where there's some variation. So I think they'd like to encourage a real focus on surgical quality, a real focus on collaborating with the patients, and making sure they have the support that they need after they leave the hospital. But I think, what's driving this is that there is huge variation in the cost of these surgeries over the episodic period, and they would like to see that narrow.
And Rob, if I could add, I think that there was some intentionality by CMS with the locations that they picked. I mean, so there's a reason why I don't think that this was all spaghetti at the wall when they were picking these locations, right? They were intentional at looking at areas that either were not maybe as engaged in value-based care or in mandatory models or even voluntary models. And I would garner that they selected locations, and we've seen that based on the data and some of the risk pool, that these are facilities that need to make some changes around how they're doing workflow, process, cost, quality, et cetera. And so I think there was some intentionality around why they picked what they picked.
Right. So I think they talk about the criteria they used in the final rule. And basically, the two big ones were they wanted to have areas that did not have a lot of experience in bundles, number one. And they also tried to get areas where there was a higher proportion of safety net providers, because one of the things that they state they want to do is get more vulnerable patients engaged with value-based care. So I'm not sure that that's necessarily a great thing. It sort of, in the bundle program, I think it's very important in total cost of care programs. But in the bundle program, especially with the post-discharge, there's some issues around patient vulnerability. Recovery is hard if you don't have a safe place to sleep at night. You don't have a good home environment. So, that's one of my big concerns with the model. But what they've done is they've tried to address that with the much lower downside risk for the safety net hospitals. So what they're hoping is that after 4.5 years, the safety net hospitals will be able to make some improvements. And by 2029, when they do bear some downside risk, they'll be ready for it.
Yeah, and there's also one of the differences in this bundle payment model versus the previous ones. There was, at least in its current format, there was requirements around health equity and social determinants of health to be able to tease out some of those, those safety net limitations and lack of access to environmental non-medical factors. I have one follow-up. Go ahead, Rob.
Okay. No, I was going to say, just in response to what you said, that's really important because each hospital has to put together an equity plan. They also use a risk model that has patient social factors in it. And one of the important things is, so people in the policy community are concerned if people who are low income and they have less access of care, so their costs are actually lower. And so what they did in this risk model is they said, we're only going to use the coefficients if they increase the target prices. So, and we found that as we look at the model that actually these risk factors, as they're applied, do increase target prices for safety net patients and safety net providers.
Yeah, to help to remove some of that selection bias and to insulate. Okay. I have one question I'd like for both of you to opine about. This is something that I've thought about quite a lot, and that is that the site of service differential, right? They're targeting hospitals that have inpatient procedures. How big of an impact is this going to have on cost shifting to outpatient versus inpatient? And again, we can't read into the minds necessarily, or unless it was addressed directly in the rule proceedings. What's the impact going to be? It just seems to me like this is an effort to shift site of service differential pricing towards outpatient versus inpatient.
Yeah, so for the 5 episodes, 3 of these episodes are inpatient only. The 2 episodes that have outpatient included in it are lower extremity joint replacement and spinal fusion. And I think here there's a clear opportunity, because they're pooling those together. Hospitals that are doing more care on the outpatient, in the outpatient setting, there's a clear incentive to shift care to the outpatient setting. But these have to be patients, if you're not hospitalized, you get treated in an outpatient setting, you're not eligible, Medicare won't cover a SNF stay. So these have to be healthier patients. So one of the things that happens, the question is, are there patients on the margin who really would be okay in the outpatient setting that previously were in the inpatient setting? But I think some of these patients, if they're really frail, if they've got a lot of comorbidities, if they have a lot of social needs, they almost have to be in the inpatient setting so that they can get post-acute facility care.
Yeah. And I would say yes and yeah. So yes, we want to be able to have the right site, right, the right care at the right location, the right provider, all of those answers. That's kind of a core tenet of where CMS is going. But at the same time, I don't think anyone's advocating for cabbages to be done right outpatient. I think that
Yep.
there's a recognition that there are medically complex individuals like Rob just talked about, but also there's incredible care variation that is occurring in these facilities, that there's not consistency in discharge processes. There's not clinical practice and pathways that are happening from the time that someone's identified, to the time that they are leaving the organization. There is not consistent care coordination that's happening after they are discharged, and all of the wraparound services that we know someone who has had a cabbage needs. And so I think that there is certainly a push for site of service, but I also think the tenet around care variation, and Rob, you said it best, cost drives quality. And quality is ultimately going to be a huge factor. I mean, think about the surgeries they selected. They are high volume for Medicare patients,
Yep.
for sure. So they're paying for it. So
Absolutely.
we need
I
more than an hour, Will, to go through all of this.
didn't mean to derail the conversation.
No, it's good stuff.
So there was the first question that was asked that we didn't address. Apologies for that. Is that about receiving copies of the presentation? We don't typically distribute the copies of the slide deck, but we will make the recording available through the Innovacer website, and we will share that recording and a link to that recording with all the attendees and the RSVPers. So, okay. Second survey says, on a scale of 1 to 5, how prepared do you feel to implement the team model in your practice/hospital? Put my timer on 30 seconds for everybody to consider our Vernier scale from 0 to 5. Just about 10 more seconds. Okay, let's close that poll and see if we can come up with some results. Wow, all across the spectrum. If you turn that sideways, it almost looks like a perfect bell curve. Good spread.
I mean, the good news is people have time, right? They essentially the next year, they have a year and a little bit before the model starts, and then they have 1 year of no downside risk. And
Right.
as Karen will tell you, I'm sure this is hard work, so you're going to need that time. But they intentionally built time into this for people to start early.
Yep.
Yeah.
And there were a chunk of the hospitals that are involved in the 750-ish mandatory panel that did have some previous BPCI, BIPSI experience, but it was not anywhere close to a plurality, much less a majority. All right, moving right along. There we go. Now we're going to turn over the floor to Miss Karen. Karen, if you wouldn't mind picking up the baton.
Sure. Well, let's talk about readiness. So I think, we saw, and Rob mentioned there, you do have some time, right? But not that much time. So when you think about the amount of transformation that is being asked and contemplated in this model, organizations are going to need to think about what role they need to play. And I know certainly the model is targeted towards acute care facilities, but there is a role that practices, ACOs, long-term post-acute, really the entire care continuum play in this model. And I think it's important for everyone to recognize that this is a larger ecosystem. And so I think CMS is thinking of that. Like to think of how you can kind of break this down in a best practice standpoint. One, most importantly, you need to be able to get your stakeholders engaged. And so whether those are your providers, your executives, your care teams, I talked about the healthcare ecosystem, understanding where your partnerships are and how you are working with either your ACO, your long-term post-acute partners are going to be really important as you're navigating and kind of thinking about best practices for episodes. Workflow, we talked about that just a minute ago around the care variation that continues to be. And so being able to focus on things like post-discharge care coordination, your transition of care, making sure that you have standardized clinical pathways. Ideally, they're automated in your EMR, right, that allow you to get consistency in the order sets, and the steps that are provided in the acute care setting are going to be really important. And making sure you have strong compliance plans in place around that workflow. And then data is going to be key. CMS will start to give data a little later in 25, but it's not going to be as robust as you're going to want and as you're going to need. And it's not going to allow you to do some of the benchmarking, the regional benchmarking that, Rob was highlighting earlier. And so there's going to be some gap around data and analytics. And certainly if you don't have a tool in place, that's going to make it even more challenging. So it's going to be important for organizations to think about how they're going to monitor performance. And it could be everything from the financials that we talked through, quality performance, but also back to your providers. I'm a big fan of provider scorecards, the ability to leverage that information with the physicians, make sure that they have an awareness of what their case mix looks like, their risk score, their cost, their quality. For each of those patient panels that they're taking care of is going to be hugely important to getting buy-in and engagement. And then most importantly, understanding that this is not a one and done, right? This is not a get ready in 25, implement in 26, and you're done. This is a forever process. This is a continuous process. And so whatever PDSA, continuous improvement, structure, tool, that you are using it as an institution, making sure that the episode of care work is woven in is going to be really important for organizations to think through. If you go to the next slide, I'll give a little more specifics around things that, as we've been working with organizations building out their implementation strategy and kind of their approach on how they're going to support this model. Here are the things that, we're recommending. Not only do you need to understand your performance around the regional benchmarks, but you need to be looking at some of those spending patterns. And I think Rob did a great job of analyzing and showing inpatient rehab versus skilled nursing, the ability to see, what kind of variation that could be anywhere from 20 to 60% of an episode cost, right? And so understanding what role those play and breaking out your spend is going to be really important on the financials. There's also an ability for organizations to really think about that care redesign. And I mentioned clinical pathways and long-term post-acute partners. And so, for example, if you don't have care compacts in place with your skilled nursing facilities that are in your catchment that you commonly refer, you don't have tracking mechanisms for quality in place or preferred partnerships. And, we were talking with a client just a couple of days ago, and they're looking at home health, and that's an area that we highly recommend, right? It's not just care in an institution that happens post-surgery. It's definitely a movement towards home health as well. And so there are opportunities for organizations to really be thinking through what does that full care continuum look like, and who are they partnering with to make sure that as patients are moving through that continuum, through that episode, that they have the right parts and pieces and support in play for their clinical teams. A couple other things to just think through around population health. We did a great talk and mention around social determinants and community health supports, but that's clear, right? So many organizations have instituted some sort of risk assessment they are doing on those social factors. The key is then matching those patients once you've identified a gap, right, to those community resources. And that's typically where organizations struggle and where communities may not be well equipped. And so if you are a population health leader and you are responsible for community partnerships, having this discussion, right, to make sure that your community partners know you're embarking on episode of care and that there may be more referrals potentially from surgical patients, or that you're working on process improvement in that space, is a really important one. Give your partners time as a heads up to engage and be supportive in this process, especially if multiple hospitals in your region are doing this program. So all the more reason that's going to drain and impact community in a different way. Um, and we could keep talking about all of the other examples, but first and foremost, at the middle of everything is the patient, right? So patients are going to need to, most organizations have good patient education programs. They talk about what you do before surgery, what is going to be expected after surgery. But this is, in my opinion, an opportunity to dust those off and really look at, are we educating and arming patients with all of the right supports they need? One, to help with self-management, and whether they might need health coaching or other supports that maybe have not been part of your traditional discharge plan for these surgeries. So there's a lot that could be added into this. These implementation plans are complex. Everything from provider compensation to governance models, right? There's a lot that really needs to be contemplated. Organizations that are doing population health work, they may be involved in MSSP, they may be involved in other alternative payment models, are clearly well positioned to take that work and elevate it even more. But understanding that this is not just another ACO model, this is really an opportunity to look internally in these hospitals and look at your cost, your internal fixed cost, and how lean you're running, and partnering with your surgeons on everything from supply chain, workflows, care pathways, drug, et cetera. Like, there are a lot of areas that organizations should be in and must be thinking about in order to bend the cost curve.
So Karen, gosh, there's so many moving parts, right? This is the chief pharmacy officer. It's the operations, it's finance, it's the case management. There's so many moving parts. I don't want to let time expire on us, because we only have about 15 minutes left on our scheduled program today. But I did want to make sure that everybody that was on the call today knows that Karen at Benevolence Health and her team is offering a free 1-hour consultation to do a gap analysis of all of these complex moving parts, and to be able to provide the background and information about the sort of the jobs to be done list. And in a not dissimilar fashion, Rob is also, and the good folks at IAC are willing to jump in and do some basic benchmarking. And of course, from the innovator side, we want to make sure that that the technology stack and the requirements for being able to stand up, operationalize, and automate as much of this possible in the background. All of those resources are part of the team that we can bring together if anybody needs help in moving things along in that direction.
Absolutely. And I know there's a couple other questions. I'll run through these last couple of points and then happy to take more questions. So, this is kind of a quick start guide, right, for organizations to think through. One, understand your performance, where you're sitting, cost, quality, right, workflow, et cetera. Engagement, getting your internal and external stakeholders. I talked about that. Will you outline some of the many leaders that are going to be needed is going to be essential. And then there's, some assessment that needs to be done across all of these areas: clinical, business, your tech, where you're going to get the data, your provider engagement. There's quite a bit there. And then there's a fair amount of kickoff. And I would say make sure this is a kickoff, early Q1 2025. Don't delay in doing that. It will take time to make these transformative changes in your organization, to communicate. And ideally, you want to be instituting all of these process changes and workflow and technology changes by Q3 of 25, so that as you start in 26, you really have a comfort of kind of where you're performing for that full performance year. Oh.
Excellent. You want to tackle, there's some really good questions.
There is. Yeah,
I mean,
there is.
in addition to the analysis around CMS loves playing chess, there's a couple of other questions that we should address.
CMS loves chess. There's probably lots of other games too. Backgammon, checkers, we could just pick, right, the list. But yeah, CMS certainly makes it interesting. I think it's clear as you watch the way CMMI has evolved with all of the models in the last 12 months, there's a lot of movement that's happening. There's a question here around Karen's crystal ball of what 25 will happen with, some of the new programs being extended. I think that it's interesting. We will see a lot in the next 90 days with the new administration coming in and what
Absolutely.
those leadership will change or not change. What we do know is that based on prior experience, when the administration was in place, they did support value-based care movement, and they were definitely looking for opportunities
Yep.
to improve quality and save cost. That was clear. And I think that will be consistent when we move into 25 and beyond. How we do it, what are the models, what changes to the models, I think will remain to be seen. What is unique about the team model is that it's written into policy, right? So it's a little different than kind of these voluntary programs. There's actual guidelines that are sitting in play with this one. So it's a little different than some of the other value-based care programs that are coming out of CMMI.
Yeah, Karen, I'd say that, I mean, with respect to the hospital at home program, if I was a betting person, I would say they are going to extend the waiver. I know,
Yeah.
the people who've been working in this program have been working closely with CMS. And what CMS is struggling with hospital at home is that they'd like to find a way to price it. I think they believe it is cost saving. The costs are less than the standard hospitalization. And so I think what they're working out, A, is a pricing model, and B is who are they going to allow to do it, because they don't want every fly-by-night operation to be all of a sudden doing hospital at home. So those are the policy questions that they're working around, but I think they will extend it while they work on them.
I agree. I would be surprised. The same thing is sitting around, the telehealth conversations. I mean, we're seeing that all of these programs that have proven to have good clinical and quality improvement have been kind of extended. I think the challenge is how do they paper it and make it long-term sustainable, right? And that's kind of where we get into a crossroads. There's a question around Gen AI. So, do we foresee a place or a situation where Gen AI could help support reconciliation of payments? So, Gen AI is a really interesting space. There's so much that's happening in the rev cycle around coding, documentation, and the ability to kind of look at, you know, payment structure. I think I need to know a little more about where they think the use for Gen AI could be. What I have seen is that there's some pretty promising tools that are helping give, reminders and bumps around clinical pathways and, anticipating needs for patients. And to me, like that's really exciting. Anytime that technology or AI could help support our care teams and remind them around care variation and help encourage best practice, to me is a win. And so I think that there's definitely some promise when we look at the new AI tools that are coming out from organizations all over.
I think also there's a question from Aaron on the costs and how that's going to affect the ability to access the inpatient rehab. And it's a great point. One of the biggest problems with these programs is that it can cause providers to go overboard and restrict necessary care in these institutions. The cost is so these are very expensive services. The real issue is how can hospitals make sure they get the right patient to the right setting post-acute? When we started in BPCI, I remember working with a hospital, and they said, "Oh, our joint replacement patients, and 70% of them go to rehab hospital." Well, why? Because they own the rehab hospital. That hasn't completely gone away, although use rates have gone down. So I think it's really important to monitor this and to make sure that people that are indicated for that care will recover best with that care should get that care. But that's a real concern of the model.
Yeah, absolutely. And I think that these are some of the nuances of episodes, right? When you're looking at care model and care variation, what's the best thing for patients at that time? And then what are the drivers for those decisions around discharge planning? Are they really holistic and care focused? Uh, there's another question that came out around the 30-day model. So 30 days post-discharge, all inclusive, right? Just like a resort. So,
Let's not
that's
get
all
carried away with
included.
that analogy, though.
Well, it's not quite all inclusive, right? Because there are some exclusions from the bundles, and so, but the exclusions are sort of these big, clearly unrelated things. So in most cases, oncology is not part of the bundle, transplantation is not part of the bundle. If there is trauma that's unrelated to the condition, it may be pulled out of the bundle, but CMS takes a more all-encompassing approach to what's in. So a lot of what's in, which includes almost all of those professional services in the next 30
Professional service.
days.
So all inclusive, but with strings. And my apologies for being broad in that statement. Those are like most other CMS models, the big guys are excluded.
Right. So I think this is just about on the wrap-up side. Which part of the team model, after what we've discussed today, or your experience in digging in, remember that bell-shaped curve that we saw, where people are all fairly well spread along the continuum. Which parts of this model do you think are going to pose the biggest challenge? And we should have a list here of 7 or 8. If you wouldn't mind checking the boxes of all of the things, if we can get those to come up from the back end. I will change my timer to be a little bit longer so that there'll be more time for everybody to
And it's multi-select, right?
multi-select.
More than one thing can keep you up at night.
I'll refrain from asking Karen, you and Rob if there are more than one thing that keeps you guys up at night.
I do want to say thank you for all of the great questions. I really appreciated the
Fantastic.
engagement from the
Yep.
audience and just asking us tough stuff, because I think when we are together, we learn together, and the questions you asked are the questions that other people have. So thank you for that.
And it, it's always more fun too, right? When you have that audience participation engagement to help guide the conversation. So yeah, thanks very much to everybody for actively participating in the Q&A. Really appreciate that. So I'm gonna, just while we're waiting for this, and this might not be a fair question, we can equivocate a little bit, but there's some of these are going to have bigger positive or negative financial impact than others, right? Picking the post-acute network, Rob, you were opining about that just a few minutes ago. Care coordination, it seems to me, is going to maybe have one of the bigger impacts in terms of where patients. Okay, another bell-shaped curve, man. We got them all across the board. So yeah, that's fascinating, Karen. It seems like that the analysis of gap analysis that you're offering up is going to be huge, because it's going to be everywhere across the board for everybody.
Yeah. And there's areas here that are not surprising, right? So finance, post-acute, these are the things that you would expect. Physician engagement is one that I hear routinely from organizations. If you don't have a physician engagement model right now where there's some skin in the game, if you will,
Yep.
how do you evaluate that and look at that is going to be really important, to create that stickiness that you're going to need to do these programs.
Yep. Great participation. And as we have 3 minutes left, let's spend them addressing the last 2 questions. And I think one of them, actually both of them, Karen, might be in your wheelhouse with conveners, and then for what sort of care coordination and tools.
So it's
I'm happy, Will, to address the convener question, actually. So
Great.
I think, with the old remedy partners, right, they were all about maximizing the opportunity. And this is where voluntary programs come in. In the team model, there is less opportunity, and there is no opportunity to sort of game in or out. And so I don't think there's not going to be a lot of remedy partner type organizations coming in. I think there will be service organizations that can provide data support, that can provide consulting support, but it's not going to be the same thing as the remedy type of model, which I think was really built around completely maximizing revenue for them, not necessarily for you. helping you, but maximizing for them.
Yep.
Yeah.
And
As far as,
uh,
go ahead.
well, I was just going to say I'll proactively address Aaron's comment about patient-centered outcomes. That as well. We missed that. Thank you for bringing that up, Aaron. We'll make sure to include that in future communications. Thank you.
For
Yeah.
care coordination, I think you're going to want to look at, you've got some very different surgical cases, that are being included. So the needs for CABG patients are going to be different than spine, than ortho. And so I think you're going to really need to look at your care coordination program and look at how you've either included pharmacy, nursing, health coaches, social workers, et cetera, and what you're going to be doing that's very specific to, the focus on the actual procedure versus the support that is needed for other needs for the continuum.
Yeah, and one of the biggest things that we see as a technology care coordination platform provider at Innovacer is that the ability to have configurability inside the system, which means that the customer can control the content, as opposed to customization, which means that the vendor controls the content. If everything has to be customized, it means it's going to cost a lot more money. Your flexibility, your timelines, et cetera, are going to be compromised significantly. Whereas if it's configurable, then you as a user of the tools can configure all of your own requirements without having to ask or pay somebody else to do it. So critically important components of selection process.
Yeah, absolutely.
Okay. I think we're going to call it a wrap. We are right on time. Rob, Karen, thank you so much. We put a lot of work into ramping this thing up and setting it out there and getting everything coordinated. I very much appreciate you guys coming and talking with us today. If anybody does have questions, et cetera, we will be having all kinds of follow-up. There's also there should be a feedback screen here if you wouldn't mind just taking another moment or two before you sign off. And I hope everybody has a great rest of the week and a safe holiday season coming up.
Mhm.
Right. Let's see if we can just finalize with the results here. And I want to say thank you again to everybody for joining us. And I hope that everybody has a great rest of the week.